Great. Good morning, everyone. Welcome to UBC Okanagan and our webinar this morning. So I'd like to begin by acknowledging that the land on which we're gathering today here in Kelowna is the traditional unceded territory of the Syilx Okanagan Nation and their peoples. But I also want to acknowledge that many of you are joining us from both near and far. And so I also want to acknowledge the traditional owners, past and present, of those lands as well. So my name is Joan Batorf. I'm director of the Institute for Healthy Living and Chronic Disease Prevention and a professor in the School of Nursing. And again, I'm delighted to host this webinar today. This is one of our partnerships in research webinar series. And we're delighted to have one of our research teams with us here today to share some of their work. There will be time at the end for some comments and questions, so I'd encourage you to keep track of those and to write them in the chat box, and we will be sure to relay those to our speakers. So without further ado then, I want to introduce our team that's speaking this morning. We have Kathy Rush, Dr. Kathy Rush, who's from the School of Nursing and is a professor there. We have Dr. Eric Lee, who's Associate Professor of Marketing in the Faculty of Management. And we have Dr. Cherisse Seaton, who is the research coordinator on this wonderful research team. And I might just say that this is one of our eminence research team clusters that was recently funded at UBC. And so involves an interdisciplinary team, and I know that Kathy, Eric, and Cherisse are going to tell you about the team and their work, and particularly their work over the last while in the context of COVID, and help us understand the experiences of rural communities. So I'm going to turn it over to you, Eric, Kathy, and Cherisse. Thank you.
Well, thank you, Joan, for that. So good morning. So my name is Eric Lee. So I'm an associate professor at the Faculty of Management for that. So today, this is our pleasure to share one of our research findings with you for that. So the title of our presentations today is Internet Access is Not a Luxury, it's a Necessity. So rural communities speak about challenges and technologies used during the COVID-19 pandemic for that. So before we start our presentation, I would just want to take some time to introduce who we are. So we are RHE-SETS. RHE-SETS stands for Rural Health Equity through Social Enterprise and Technology Synergies. So this is a multidisciplinary team of academics from nursing, medicine, social work, management, and computer science. But working together for that, we really want to bring different perspectives and also expertise to collaborate for a common goal, to explore innovative ways to leverage technology and local organizations to promote rural equity. So we have three objectives. So the first objective is really want to co-create a hub of research excellence that promotes rural health and healthcare equity. And then in our regions, so the second objective, we would like to partner with different rural communities to develop and implement rural-centric techno-social enterprise solutions to advance equity. So for many of you, you might be aware that our healthcare system is really focused on using the urban-centric approach for that. So we focus on the density of the populations and also distance from the urban core for that to decide where we put the clinics and also a general hospital there for that. But in the rural community for that is totally different context. So because if we're using this urban-centric model for that, so that won't be have limited health service providing to serving these populations for that. So having said that, just our team is really want to kind of create, working with our partners to create equity landscape to enhance health and healthcare for rural disadvantaged populations. So we do have like 3 target populations we would like to serve in our eminence grant. So the first one is the children and youth. The second populations would be the indigenous people. And the third would be older adults with chronic illnesses. So we found that they're facing the most challenge with this kind of like with the current healthcare system. So as mentioned earlier, for that is like in the place of, and then we would like to kind of create health and address the health and healthcare disparity exists in the rural community is because of the systematic force such as socioeconomics, history, powers that disproportionately disadvantage some groups. So our group is committed to reduce health inequity and maximize health outcomes for rural citizens. So we want to learn about ways that technologies could be used to address the health equity further. We're all interested in learning about the possible role of local organizations, for instance, social enterprise, in kind of like how to using these social objectives to meet the general goals or to maximize the community benefit. So we also want to hear about what communities are already doing and also to learn more about their opportunity to engage local organizations to address health needs. So having said that, just like here is our team. So we're still expanding or growing in our second years for that. So the team is co-led by Dr. Kathy Rush and also me for that. And again, like Joan mentions for that, so it's wonderful to have Dr. Cherisse Seaton as our project and coordinators. And our team, as you can see on these slides, for that, so we composed from researchers from the School of Nursing, School of Social Works, and Department of Computer Science, and also the Faculty of Medicine for that. So it's a truly multidisciplinary team for that. So as I say that we enjoy every moment we meet together and work together. So, and I just want to briefly go through today's agenda. So we will talk about the challenge faced by the rural communities, and then we'll talk about, especially during the COVID-19 pandemic, what kind of impact these pandemics on the rural communities. And then we will talk about our COVID-19 surveys. It's really focused on the technology usage in the rural communities we conducted earlier this summer. And then so we will end our presentations with some recommendations for future research direction and also open up for general discussions for that. So we will save time for Q&A for that. If you have any questions for that, feel free to use like the text box or the chat feature on Zoom for that to type in. We will address that one by one. So I would like to pass the presentations to Kathy to talk about some challenge faced by the rural populations. Kathy, that's your turn.
Great. Thanks. So it's a pleasure to be here today. And I just want to start off with just giving a little background in terms of rural populations and building on what Eric really addressed earlier on in terms of health and healthcare disparities. So we are well aware that rural communities, populations are diverse in size and density, with on average probably less than 5 people per square kilometer. And they're often fluctuating with people moving in and out of communities. And 18% of our Canadian population live in rural communities, and in BC, those who are 55 years and older represent 25 to 50% of our rural population. And about 1/3 of BC's Aboriginal population live in rural areas. So we have well-known health disparities that disadvantage our rural populations. And so you can see listed here in this green box some of those disparities, with rural populations having a greater prevalence compared to their urban counterparts, a greater prevalence of 2 or more chronic diseases such as heart disease and diabetes, poor mental health, unhealthy behaviors like smoking and sedentary activity, greater obesity, lower life expectancy and higher mortality, and they are overall more affected by the social determinants of health, such as poverty. And just a note that our rural Indigenous populations, so when we look at these health disparities, our rural Indigenous populations really have even greater health disparities with poor health outcomes compared to their non-Indigenous counterparts. Next slide, Eric. So in addition to health disparities, there are also healthcare disparities that characterize rural populations. And so these would be familiar to many of us, and certainly they are served by fewer physicians, approximately 8%. they experience provider shortages. We know that provider shortages are prevalent in urban areas as well, but the impact is felt to a greater extent in rural communities. They have less access to specialty care, fewer healthcare facilities. So oftentimes they don't have a community hospital. It's been closed or it's been downsized in some way. And so they do have less access to services. And in these COVID days, they lack some necessary equipment like ventilators. Some evidence is showing ventilators lacking in rural communities. And there's inadequate infrastructure, and specifically related to transportation and also to high-speed internet. And on the right, you'll see some statistics that certainly indicate this digital disparity with urban communities having 97% access to high-speed internet compared to just 37% in rural communities and only 24% in Indigenous communities. Next slide, Eric. So those are pre-COVID trends in terms of health and healthcare disparities. And we just ask, has COVID increased those disparities for rural populations? Next slide. It's probably not an easy question to answer that we can answer, but certainly to date, there is certainly a lack of Canadian and BC published evidence for the impact of COVID-19 on rural communities. And that's largely because data is not disaggregated. And so rural and urban are all combined into one data set. There is some beginning evidence in the US that has compared COVID case rates and COVID case fatality rates between rural and urban communities. And you will see in the graph in the middle that on the x-axis, you'll see an index of relative rurality. So as we move from left to right, rurality increases. And then we see on the y-axis on the left, the COVID case rates, and on the right, the case fatality rates. And so you'll see in blue that as rurality increases, so case rates, COVID case rates decreased, but in red, you'll note that that as rurality increased, that case fatality rates increased. And so that sort of tells us that even though rural communities, and this is in the US, a different healthcare system entirely, that COVID case rates occurred less frequently, but when they did occur, they tended to be more fatal. Next slide, Eric. And since COVID, we've also had a widening of digital health disparities. And so the Canadian Internet Registration Authority has recently reported that urban internet speeds have nearly doubled while rural speeds have really plateaued. And further evidence shows that median download speeds are 10 times slower for rural compared to urban Canadians. And this orange figure just indicates some of it was basically from the Canadian Internet Registration Authority, but just showing the megabytes per second speeds, the 15.7 for rural and the 72.4 for urban. And it's over to you, I think, Eric. Back to you.
Yep. Thank you, Kathy, for that. So thank you, Kathy, for really kind of like presenting the challenge that we experience in this rural community, especially in the beginning of the COVID-19, and now we're still in the middle of this pandemic for that. So our team in the very beginnings of the COVID-19 is already kind of like met, and also really think about like what challenge our rural community, especially in British Columbia, in the interior regions, for that experience for that. So we come up with what we call the rapid surveys for that. The purpose of these surveys is to we want to kind of better understand what challenge rural community members are facing during the COVID-19 pandemic, and also how technologies is being used. So when we talk about technologies for that, so I just want to say that we just don't want to limit it to the telehealth or the health-related type of technologies, but general technologies like even like using Zooms or video conferencing or other form of technologies is supporting the everyday life that we also want to capture in this survey. So we started surveys by the end of May. So we finished the surveys in July 8th and 2020 for that. So we have a 6 weeks period for that. So we're using the UBC Quadric survey platforms to conduct. So we're using some structures and also some open-ended questions to ask our participants how they experience during this challenging time. So, and by July for that, So we collect like 279 samples, but that is quite interesting for that. So we have over 70% of female participants from the rural communities. So you can see the majority of our participants is from the interior health region. So 3 from East Cooley's for that, 99 from the Cooley boundary for that. But we also have participants coming from the other regions in British Columbia, for instance, like from the Lofton Health or the Vancouver Islands Health regions for that. So the table on the right-hand side, I'm not going to present, but you can really see the trends for that. So the majority of our participants are more like the mature adults, but that is over 55 years old. And then so we do have some missing data, and most of them got a trade certifications or university degree. And this cities for that, I think is really presenting the trends of the demographics of BC for that. So the majority of them are Caucasians for that, but we do have some like and 24 individuals from the First Nation and also Métis for that. So it's really capturing the rural community demographics nicely. So here would be some challenge we would like to present for that. So the top challenge they identifies for that is about like limited access to friends and family members for that they're feeling lonely or isolated. But when we go to the technologies related kind of a challenge for that, you can see we kind of like we circle in the red circle here's for that. And then so the limited access to healthcare services such as hospitals and doctors is really a big challenge for the rural citizens for that. And I also found that there's a limited access to mental health services in the rural regions for that. And then so, and of course, like the last challenge and we highlight here for that, just like the limited access to stable internet and mobile connection. It's like what Kathy mentioned earlier for that. So the disparity in terms of like the digital connectivity for that is salient, especially during the COVID-19 period. So here will be some qualitative kind of codes, but that we just like draw some. So when individuals is talking about the social isolations and access to the friends and also social support for that. So we just found one code here. So being very isolated for that. So these participants for that, and then because her boyfriends have to move to the others kind of back to his families to supporting them for that, and she feel extremely isolated during the pandemic for that. So it's not uncommon, and then so in the rural community for that, so because like usually they have family members in other regions or in other community for that, and it's really kind of like creating a challenging times for these individuals. Access to family members for that, inabilities to visit their grown children and who live away for that. So that's also kind of like really illustrates the situations in the rural communities for that. So many of the adult children for that, they are actually not living in a more like metropolitan areas like Vancouver's or Kelowna's. And then, so job insecurities is also, we found that is a big challenge for that. So being evicted and also losing the contract on the same days for that is kind of like really showcasing the challenge that rural citizens are experiencing in the beginning of the pandemic time for that. When we talk about the personal health, including the mental health issues, we also capture there's quite a lot of fears of COVID-19, and then also the anxieties and also the depressions. For instance, this code is talking about like the cabin fever, so taking to the extreme. So they really worry about, so I'm thinking about like the time we conduct this service, but that is the beginning of the summer, but they're already kind of like forecasting the worries or the concerns about the winter isolations and followed by the COVID-19 isolations here. So of course, like we have these like access to the health service, access to the doctors, and also cancellations of surgeries, and also the care home for that is become a very kind of like crucial and clear challenge for the rural residents here. So the top rated rural priorities, again, here for that we can see, and then over 30% of the individuals, they found that access to health services and including the hospital and doctors, and then so would be one of the top priorities. And then so access to stable internet gets 21.9%, and also access to mental health services, they got like 16.1%. So it's just a more a summary is what I told. So when we talk about like the health service and the telemedicines, but that I will probably pass back to Kathy. So Kathy, that's your turn. Kathy, you're mute.
Yes, in these next few slides, I'm going to talk about telemedicine and other healthcare services like mental health services, and then just general technology findings. So as Eric mentioned, certainly healthcare services ranked among the top 3 priorities for about 31% of our participants. And you can see on the left that about 1/3 of our participants indicated that they needed health care, and 88% had used telemedicine during the time of the survey, but only had access to it, pardon me, had access to telemedicine, but only 44% had actually used it. When you look at the lower table on the right, you can see that about 31% had used telemedicine somewhat more often or far more often during COVID than before COVID. So there was certainly an increase in telemedicine use as we might expect. And at the top, you can see that there were probably about 28% of participants who had communicated with their doctor or healthcare provider somewhat more often or far more often than pre-COVID. So you can see that a good number, nearly 50%, had communicated about the same with their providers. Next slide, Eric. We were interested in learning about our participants' satisfaction with telemedicine, and so we administered, there were 3 or 4 questions where and we are reporting here on participants who agreed or strongly agreed with these 4 items. And so there overall was quite a bit of satisfaction with telemedicine. You'll see that about 3/4 of our participants felt comfortable communicating with their healthcare provider using telemedicine, and nearly 90% indicated that they would use telemedicine services again. However, you see that only 2/3 of participants really found telemedicine to be an acceptable way to receive health services, and a similar percentage were satisfied with the quality of the service. So that indicates that there were 1/3 of our participants who really were not as satisfied with it, with telemedicine as an acceptable way to deliver services, or were as satisfied with the quality. We also had our participants, as Eric indicated, respond to open-ended questions, and the question that we asked them really was, what were your experiences with telemedicine? And you'll see that there were a variety of responses. We've kind of surrounded this figure with some of the open question responses. And at the top of the chart, you'll see those who were more satisfied with telemedicine services, and their satisfaction related to not having to travel, not having to cover the cost of hotel accommodations, while they still received information that was comparable to really the information they would receive if it was an in-person visit. And you'll see on the right at the top, another participant who had been on a wait list for a physician for a very long time was delighted to have telemedicine, because finally this individual could actually have a physician visit. So there was a great deal of satisfaction, but there was also dissatisfaction, and a lot of the dissatisfaction related to the impersonal nature of telemedicine, to not having the human touch, and some spoke about really not even seeing their providers for some pressing issues, such as the person on the left who said that they hadn't seen about a breast lump because they assumed that the mammography services would not be available. And then there were just general dissatisfactions with, again, telemedicine being more for administration and serving the system rather than the people. At the very bottom, you'll see one of the overwhelming dissatisfactions with telemedicine. It wasn't so much with the telemedicine, but it influenced their ability to use telemedicine, and that was their lack of internet connectivity. And so the name of our presentation reflects this particular comment. At this point, the internet and access to it should be considered a utility and not a luxury. Next slide, Eric. We were interested in learning more about the relationship between telemedicine satisfaction and literacy, and we administered 2 literacy measures. One is an e-health literacy scale, and that really combines knowledge and skills and comfort related to finding and evaluating and using health information to solve problems. Whereas digital literacy has to do more with knowledge about and abilities to use digital technologies like mobile phone apps. And so you'll see here that we did find a positive correlation between telemedicine satisfaction and both literacy scales. We also found that age was not related to telemedicine satisfaction with respect to e-health literacy, but there was a negative relationship between telemedicine satisfaction and digital literacy. So as age increased, so telemedicine satisfaction decreased. We also found that women had significantly higher e-health literacy scores than did men, but we did not find that same effect with the digital literacy. Next slide, Eric. It's more specific to mental health services. You'll maybe recall from Eric's earlier slide that 16.1% of our participants identified mental health as one of their top 3 priorities. And so you'll see on the left here that about 2/3 of participants had access to online mental health programs. But if you look at the right and the upper right part of the table, you'll see that just 3.6% had actually used those online mental health programs somewhat more often or far more often during the pandemic than pre-COVID. And with respect to the virtual or phone mental health services, you'll see about 3/4 of participants did have access to those, and about 12% had used those somewhat more often or far more often during COVID than before COVID. Next slide, Eric. And this is just looking at technology in general, so not specific to telemedicine, but like Eric said, a more generic look at technology. And again, about 1/5 of our population, of our sample, identified access to that stable internet as a top priority. You'll see that while they had 98% had access to the internet, it was really the quality that was the issue for them. And there were just 4 participants who didn't have access to the internet, and that mainly related to connectivity, but also to cost of the services. You'll see that our participants use technology about like a large percentage, just over 70% used technology to connect with family and friends somewhat more often or far more often during COVID, as we would expect. And you'll see on the bottom that about 52% had used technology to gather information during COVID somewhat more often or far more often during COVID than before. Next slide, Eric. We asked our participants which devices they use to connect to the internet, and you'll see here that desktop or laptop computers and smartphones were at the top of the list, as we might expect, with tablets coming next, and then to a lesser extent voice assistant systems and other devices like smart TV. We asked if participants had enough connected devices to meet the needs of their household, and you'll see that a little over 10% did not have adequate connected devices. And you'll see that, again, it relates back to the internet. It's a recurring theme throughout our data, and certainly the woes about the internet and not having high-speed bandwidth. And then, of course, with having very limited devices, you'll see one participant talked about the competing demands with parents needing to use it for their work-related activities and their children needing to use it for online learning. Next slide, Eric. And finally, we asked about what the biggest challenges around technology were, and I know I'm sounding like a broken record here, but you'll see that certainly technology issues and quality was the most common response, with 37% of our participants indicating this is an issue. Terrible internet, it's slow, it stops, it's very poor connections, with one participant even talking about having lost bandwidth during COVID, consistent kind of with some of those data that I reported earlier, and not being able to for example, complete a video call or stream a movie, those types of things. So really very much of a challenge for people living in rural communities. But we asked them also what was positive about using technology, and you'll see here that technology kept them connected, socially connected to family, friends, to have family gatherings, and technology was also very convenient for, you know, nearly a third of participants, with being able to use a variety of platforms without having to leave home. Over to you, Eric.
Great. Thank you, Kathy, for that. So again, just like based on what Kathy just presents for that, so we just like summarize and categorize all these challenges and also kind of like this insight into different categories when we talk about rural-centric healthcare delivery for that. So we found like 4 kind of like common theme for that. Is one is talking about like how this impact the population health components. So that's the top box. So rural communities for that are very diverse, as Kathy mentions, for that they have different needs and different wants for that. And then so during the COVID-19 for that, we can see just like all these kind of challenges and also the needs and what is kind of like changing dramatically, and the technologies and also the access to the technologies is become very crucial. But the data disaggregations to understand rural consequences across diversities for that is still an open question. So for us for that, so really thinking about it from general day-to-day connectivity with friends and families for that to really talk about like access to the surgeries and hospitals, the healthcare professional for that. So we just need to kind of keep further is exploring what would be the health impact. So the second theme we identify for that is more like the left-hand side for that is the pandemic impact of health service delivery. So it's right towards that needs ongoing input from the public about the impact and healthcare distancing using the virtual care modalities for that. For instance, for that, just like without going to Vancouver to meet the specialists for that, the technology actually sometimes bring the benefits into the rural citizens for that, because now they just like have to get on Zoom or maybe other platforms to connect with their physicians or specialists. But of course, like Kathy repeatedly is really mentioned that the connectivity, the quality of the internet access or the infrastructure sometimes frustrates the rural citizens. So, and then the bottom part, they also found there's a need to kind of further explore how the development and implement different solutions. So rural, as mentioned, few times here today for that. So it's not a mini urban. So what would be the infrastructure, what would be the mechanisms or the model we can set up to make sure it's just like we hear the voices of the rural citizens is crucial. So last but not least, but that's just like there's also other impacts that's unintended consequences for public health measures for that. So the access and the impacts of the pandemic and other measures such as like the business closure. So earlier we talked about some job insecurities issues, and then so I think we have to really pay attention to how these kind of social economic impact and also influencing like citizens like access to the healthcare services, and also the density or individual density is relatively lower. And then so when the ministries or the provincial governments decides to kind of like restructuring or reconfiguring the health service delivery for that, so what would be the impact to these citizens and then so in the rural and remote community for that. So having said that, it's really kind of like we want to kind of finish up our presentations with this additional participant form. And then, and so consistent internet access is not a luxury. We talk about that. And then, so it's an essential lifestyle. So when we're taken for granted for that, so so we have to really rethink about like access to the internet. It should be a necessity. So it's an essential worker currently working from homes. Having consistent internet service is essential. For rural communities, several hundred people, that's not acceptable, and they also need to be addressed for that. Really thinking about how this impacts the service delivery. So the people could begin accessing mental health support, and the people are also struggling with addictions who didn't necessarily have cell phones or housing. So there's a larger picture kind of issues we have to address, and how these kind of the pandemics impact others. So the seniors are afraid, and then thieves increased for that. So that's more like just not as health, but it's more like the societal issue. But it's really kind of like seeing the chain effect and how we create create a better rural-centric health service systems or infrastructure to support these populations. So there also is kind of like seeing the emotions of compassion and empathy occurrence, people tired, frustrated, scared, and lately angry. So really thinking about like these kind of like changing emotions, they're always kind of like bouncing back and forth between like the rural citizen. It's pretty sad to say that. It's just like when we're sitting in the urban core for that, so we don't really feel this pain. But when we're seeing this quotes from our survey for that, we start really kind of pay attention for that. And going back to our topic for that and how we close that, the health disparity between the rural and also the urban. So it also kind of like gives you some kind of a good thought about the internet for that. So it would be lost without the internet, or at least not very lonely. So I know I can help right away if I need it, also through telephones or internet for that. So as mentioned earlier for that, just like people actually welcomes the technologies and also see the values of technologies they bring in for that. We kind of like without traveling around with these kind of like close connections through the internet. So video conferencing, FaceTime has been extremely effective. This one participant has also mentioned that. They also feel that just like if COVID have operated in the health fields to use technologies in a way they might have been kind of hesitant to do in the past. So he's hoping they continue past the point where it is necessary for that. So this particular informant is also thinking about the future. So even after the COVID-19 pandemic, and then so what would be these technologies is helping the rural citizens to access to different healthcare services in a more like substantial, sustainable ways. And so having said that, just like it's come to the conclusions for that, we always talk about like the different determinants of health for that, and then from gender to cultures to educations for that. And now we have these technologies coming to our communities, but that is helping. It's really kind of like coming to the open discussions. I would like you to invite every one of you here today to really talk about some future kind of strategies, and also want to pose these like future research directions and then for our co-explorations with that. So there might be some needs to compare different rural communities and also regions in Canada for that. So we know that in BC for that, different communities have their own different historical ties for that and structure. So I think it's very important to compare some like different rural community needs for that because it's very diverse. And also I think that might be the good time to really think about the seasonal impact. So while we conduct this survey for that is the beginning of the summer, while food and also travel is still available. And then so, but now we are starting the winter time for that. And then so maybe a lot of highways is going to be blocked, and of course like the local produce and also all the economic activity is going to slow down or even stop with that. And how this technology usage is kind of changing with the seasonal impact. And also thinking about like compare the telemedicine usage and also the user experience between, let's say, the urban and rural residents with that. So that would be some future research directions. So having said that, I would like to thank you so much for joining us today for that. So we shall have like 15-20 minutes for questions and also the discussions for that. Thank you so much. Yep.
Great. Thank you very much, Kathy and Eric, for this presentation. And I know there were some questions in the chat box, and I think Cherisse has very capably handled most of those questions, but do add your questions to the chat box. I guess I'll begin because I have a question. When you refer to telemedicine, are we just referring to like telephone consultations or appointments with your physician? Because I raised that question because of the concern about losing compassion, empathy, the richness of a face-to-face interaction with your healthcare provider. And I think with only a phone appointment, you lose some of that richness and opportunity in a face that would be available in face-to-face counter. So it made me wonder, what kind of telemedicine services are people getting? And what do we need to provide to ensure that patients are really getting the quality of care and not just a second-rate care that they need? So any comments about that? Kathy, you've done a lot of work in this area.
Good question, Joan, because it's interesting that you asked, because we, in this particular survey, this particular COVID survey, we did find that telephone was used a great deal. And partly it was used a great deal because of connectivity problems that made the video portion of telemedicine difficult. So we would encompass, like telemedicine does include, or telehealth does include, both telephone and the videoing, and the use of other devices as well. So it could be texting or other types of things, but the most common telemedicine modality right now is the telephone. But many of our participants talked about wanting to have the video option, but they oftentimes didn't have the video option because of the constraints around their bandwidth, their high-speed bandwidth. And it's interesting because I've been involved in another COVID study where we have actually asked providers about their use of technology, and oftentimes they default to telephone because many of the participants, they are concerned about, particularly the older population. They feel have maybe more challenges with using the technology, the more advanced technology. And so I think that there are various factors, I think, that account for why the telephone is actually used predominantly. But I also worry very much about about the relational aspects and how, that human touch is lost with really just a telephone. And a telephone for some people is hard because they can't hear either. So if that is sort of being used predominantly, other people they're not getting probably the quality of care, they're not hearing the information, those types of things. So I think that using telephone alone is a real concern, and we do need to do much more work in terms of looking at those other options and enhancing those other options, making them available. Yeah, because basically providers are paid for both at the current time, although there's been some talk about them losing, right? They got paid less for a telephone call, right? So maybe that will force people into using video a little bit more if that happens. So I don't know whether I've answered all your question or not, Joan.
Yeah, no, that is helpful. I see there's lots of other, we could have a conversation about this for a long time, but I see there's lots of questions in the chat box. So I'm going to turn to some of those. The first is, this is from Tanyas, do you have a report that outlines your findings? And before you answer that, I'll just mention that we're recording this webinar, and it will be up for people to look at and share with other people the links. So that part of the findings will be there for people to refer to. Do you have any other suggestions or comments about a report?
We will actually have a report available eventually. We are, we certainly, with respect to, we are putting together or kind of synthesizing all of the findings for this. We will be publishing them, but there will be a report available that we certainly can, put on our website, or, provide other ways to circulate that.
Right. So I would encourage people who are interested in the report to watch the website for RHE-SETS, and also you can always contact Kathy or Eric or Cherisse as well. This question from Mike relates to kind of the conversation that I had just with you, Kathy. Mm-hmm. How is the doctor-patient relationship affected using telemedicine? Are patients more open about the disease and illness when interaction via audio or video call? Any mm-hmm. thoughts about that?
I think that's a very good question, Mike. I do think that I think some people have had quite positive experiences because we saw that in some of our findings, that some were quite highly satisfied and others were not so much. I do think that there have been some some who have thought that perhaps even mental, like maybe it's not as easy to use telemedicine for mental health appointments, for example, but I think that there can be a great deal of satisfaction from some people, right, in being able to, you know, have that connection maintained regardless of how it happens. If it can't happen in person, it needs to be maintained in this particular way. I think for the most part that people, I think, you know, Mike, I can't really comment on that really easily because I just really don't have data about that per se. But I do think that people likely are similar, right? If they tend not to disclose a whole lot in person, they probably tend not to disclose a whole lot in terms of, you know, of using telemedicine. So I think if people are more open, just, you know, naturally, that will carry over into a telemedicine call or appointment. So I think a lot of it probably has to do with that. And people, yeah, and I think that because it's sort of been the only way to do business these days, that people are probably trying to take advantage of, you know, letting their providers know what's going on. So I have a hunch that probably people are opening up about it. I've had some people say, my provider has tended to shut off an appointment too quickly. And so I haven't actually been able to share all that I've wanted to. So I think it's probably a provider thing as well, that if providers are, you know, wanting to maximize use of this modality, that they will make the time for their patients as well, and not just hurry into it and out of it. So right. I don't know that answers it, but that's a great question, I think.
Yeah. I mean, I think that this whole rapid move to using telemedicine has provided a lot more openings for us to research these, these influencing factors. And because the fact that providers don't get those visual cues from patients is also a factor here as well, that they're limited by what they hear and what might be between the words.
Yes, exactly.
I'm going to follow on, because what follows on from this is another question from Mike about how does telemedicine and telehealth fuse together, or are they a separate entity? How are we defining those terms?
Yeah.
Or are they interchangeable, or what?
I think that they probably are interchangeable, and I would have, like, I think we chose telemedicine, but my preference would have been telehealth, because telemedicine kind of denotes that it's more the domain of medicine, and you know, and it's, whereas obviously telemedicine is broadly used by all kinds of healthcare professionals. So I do think that yeah, they are oftentimes used interchangeably. Yeah.
So Eric, Randy's got a question about plans to publish and share with policymakers about the possibility of addressing the lack of access to adequate bandwidth that so many of the participants have noted. And being the marketing expert you are, I'm wondering how you can market this to our policymakers and convince them that we need better bandwidth in rural areas.
Well, I think that's the beauty of the multidisciplinary team, right? And so I think one thing that I think the importance of these surveys would be is really providing the evidence, and we are collecting like the voice from the rural citizens for that. I think it's kind of a very important piece of evidence to show the policymaker. And of course, it might be a short process for that, but I think at the end of the day for that, I would say the policymakers and also other key stakeholders. So I think we have a constant conversation that's really talking about like, so even the policymakers are allowed to kind of put aside maybe some budgets to kind of rebuild the infrastructures and to serve the rural community for that. But we need to kind of get, let's say, a business stakeholders to join to build the structure and kind of providing the service. But I think that would become as a package to kind of presenting, okay, these would be the cost benefit. So there will be some cost, but at the end of the day for that, so how we can actually build a better communities or to serve the rural residents, and then really thinking about like the cost, and then not just like from the government perspective, but for the community, and also from for the residents for that. So I think we have constant conversations is talk about some rural citizens actually like thank you to have the technology because now they save thousands of dollars to travel to Vancouver to see the physicians for 15 minutes. And then so that I think that should be in that calculations or at least like in that presentations to the policymaker. So we are not just like talking about the money to build the infrastructure to have better bandwidth for the citizen, but really thinking about like the economic trade-off, the time, and also the difficulty, not kind of, and of course like those like stress and also the emotional components with that. Oh, and now I have to drive like 5 hours to the Colonial General Hospitals to see the physicians for an hour or maybe half an hour. I think these all should be part of these metrics and also the conversations.
Yeah.
But happy to work with any rural organizations or groups here to, again, I always a big fan of collective impact framework for that. So we have to work together rather than just like solely rely on, let's say, few of us here from UBC to do that talking. But yes, I think we happy to keep exploring this opportunity.
Great. Yes, and for our viewers, I know that Eric's got lots of keen students who need projects, so that they can maybe help us do the economic evaluation here to support this argument, working, of course, with the rural communities on that task. So Doug has a question or a comment. Fascinating and important work. Are you connected with the Center for Rural Health Research at UBC in Vancouver? Dr. Cornelissen just published this work that seems to align with your research and provides a link to a survey there. I know that that group has also been doing some work in this area. I know often they're focused on maternity care, but, but they're probably being a bit broader than that now. Do you have any comment about that, Kathy or Eric?
I know we work with some of the same rural partners that they work with as well. And so, and I am familiar with Dr. Cornelisen's, some of her work, and we haven't really partnered with them directly, where we've been, working more with our rural communities in relation to this, but this is probably an important, it's probably important to reach out to the group and, share what we're doing and have some synergies there.
Great. So Tanya says, it seems to me from your research that access to reliable internet is a bigger challenge than access to connectable devices in rural communities. Would you say that's true? In terms of advocacy around this issue, would you recommend targeting policy change at the local, provincial, or federal level? So there's two questions there. The first about what's the bigger challenge? Access to devices or a reliable internet? Or is that a chicken and egg question?
Well, I just jump in first, and Kathy, feel free to follow up on that. I think even everyone have access into smartphone devices, but they didn't really have kind of a stable or reliable internet access for that. So it's just like a piece of devices, but we didn't really have the usage. And I think the connectivity would, to me, just like the top priority. And then so access to the smartphone devices or different kind of technologies in general for that, I would say is the secondary. Why I'm saying that for that is more kind of like to me is talking about a couple $100 investment, and then versus like is multi-million-dollar investments for that. So I think that would be the crucial point.
Right.
So I probably like Kathy to follow up.
I guess I just wanted to respond, I guess, to the advocacy piece, because I have heard people talk about like access to the internet and high-speed internet is kind of a human right these days, and also to the fact that some have called it a social determinant of health, because it now is determining whether people can access care or not. But I do think that there is some advocacy needed, and I know that at provincial and a national level that there is work being done in this area. So and it's obviously had to be heightened with COVID, but it may be that we do need to be more active in pushing it, because certainly it doesn't happen overnight. And I know even some rural communities who have had to venture out on their own, right, to get their own private access, high-speed internet, and they're on this particular call today, or this particular today. So they, you know, the advocacy efforts, I think, have to be ongoing for sure.
Mm-hmm. There's a question as well, thanks for that. There's a question as well from Mike about your results related to e-health literacy and digital literacy, and just wondering how you define those and how they're different. So e-health literacy and digital literacy.
So Mike, yeah, I jumped over that perhaps a little too quickly. I did try to define them, but the e-health literacy really has to do more with people's comfort and skills in being able to access and use information, whereas really the health literacy end of it is more about people's knowledge and skills in using the actual tools. So it's different. One has to do with the, you know, using information, accessing and using information, and the other is more about using the tools.
Mm-hmm. Great. Hopefully that helps. I think that does help. Thank you. I have a comment from Nellie saying, and maybe Cherisse, you might want to comment on this. I think it's important to note this was an internet-based survey, and so for the most part, these folks did have devices. So I don't know, Cherisse, you were in charge of the survey. Do you have any comments about who was able to do the survey and who might not have been able to?
Yeah, I think that's really important to note, because some of the larger literature shows that there are many rural and remote individuals who don't have access to the internet at all. And so we wouldn't have sampled them because we didn't have a paper survey, we didn't have a telephone survey, it was just an online survey. So we are only sampling those folks who had access to the internet. And so but I think that's still really telling around how many people brought up the challenges with the reliability and quality and affordability of that internet. So even though they had access to the internet, it still was very poor in most cases.
Yeah, and so I guess we can expect that it's only more difficult for people who don't have access and who might have to go to the neighbors or a friend or family member to access their health care over telemed, or even travel a distance into a larger center where they might have be able to get internet access. So I see our time is almost up. There was one question early on, and we haven't really addressed this topic very much. And I wondered if you wanted to talk a little bit about it. It was about the representation of Indigenous people on the team and in your work. And I know a comment, I think, Cherisse, you provided a bit of a comment, but I wondered if you wanted to add anything. It's something that we haven't talked about yet, even though it is a focus of for your research. Do you want to say anything about how indigeneity is represented on the team, and anything else about that?
Did you want to say, Eric? Or do you, yeah, so we do have actually some Indigenous scholars working on the team, and we have been actively working, you know, with trying to partner with some Indigenous communities with this research. It has been challenging because they have had, you know, just with COVID, it's been a crisis for them as well, and so I think it's been a little more challenging to be able to again, sort of secure the partnerships that we're looking towards, but we have been working at it sort of consistently for several months. And in terms of the COVID survey, I think you did notice that we did actually have representation from our Indigenous. We had some Indigenous participants, so they were represented. We didn't do sort of a sub-analysis of sorts, but they certainly were represented in the survey findings. Eric, did you want to add anything?
Yeah, I just want to add that just in year 2 for that, so we will invite an elder as our advisors to the reset team for that. I think that would be a very important step, and to really kind of like engaging the indigenous communities with I would say in our formal structures for that. And also we work with like different organizations and communities, and we also work with like Candice Norin from our Office of Research and Studies Office, and she's also in First Nations. And so I think through this kind of like formal and informal channel for that, we just want to really make sure just like we won't exclude or left out any kind of like indigenous voices for that, and also we are really kind of like seeking ways to make sure just like all the findings and all the insights we are sharing with like all the communities we are serving, especially in the rural and remote communities. Yep.
That's great. Thank you. I see we've run out of time. I know we could have this conversation for a while. And I see in the chat box you've got someone who might be interested. And so I encourage you to reach out. Also, I might just mention to our audience that you are a team that's only been in operation for probably less than a year, I think, or about a year. And so really still building partnerships. And so if anyone listening to this is interested in partnering or linking this group with a rural community, by all means, reach out to Kathy and Eric here at UBC to start a conversation about that. So I do want to thank all of our panelists today, your Kathy, Eric, and Cherisse, for joining us and presenting your work. This is really a great way to launch this research cluster, and very interesting information that look forward to the next steps in building on this research. And I really also want to thank all of the people who attended today and for their comments and questions. They were really great. And we are looking forward to next steps. And so we'll welcome you back anytime. So thanks again. And I hope everyone has a great day.
Great.
Thank you, John.
Thank you all.
Thank you, everyone. Thank you. Have a good one.
Bye.